Welcome to another session of ePath to Success. I'm Dr. Sapna Chaman, and I'm here to take alveolar bone. Alveolar bone is another important topic for UG exams, PG exams, as well as Viva point of view. So let me go into the detail. Alveolar bone is an important part of the periodontium. Periodontium includes both soft tissue as well as hard tissue. Soft tissue includes the gingiva and the periodontal ligament, and hard tissue includes the alveolar bone and the cementum. Coming into the contents, we'll be dealing with the definition, the classification, the composition of the alveolar bone, the function, alveolar process, into the structure of supporting bone, gross histology of alveolar bone, and the clinical consideration where we will go into the age changes as well as the diseases related to alveolar bone. Now, as we all know, alveolar process is a part of the jawbone in which the teeth are found, or where the teeth are located. It is mainly dependent on the presence of teeth for its development. So according to the definition by Carranza, alveolar process is that part of maxilla and mandible that forms and supports the tooth socket. So there is no definite boundary between the alveolar process and the body of maxilla or the mandible. In maxilla, it is called as process alveolaris, and in case of mandible, it is called as pars alveolaris. Now, what are the functions of alveolar bone? Alveolar bone function is very important because it provides the space for roots of the teeth, and insertion of Sharpie's fibers into alveolar bone helps in anchoring the tooth. It provides little movement to the teeth for better occlusion. It holds the tooth firmly in position after mastication. It acts as a shock absorber by distributing and absorbing the occlusal forces. Both periodontal ligament and alveolar bone plays a major role in distributing the occlusal forces. It supplies the vessels to the periodontal ligament. It protects the developing permanent teeth and also supports the deciduous dentation. It guides the eruptive movement of primary and secondary teeth. Now, coming to the composition of alveolar bone has both organic and inorganic part. The major portion is the inorganic matter, which is 67% hydroxyapatite, whereas 33% composes of organic, where type 1 collagen is 28% containing glycoprotein and proteoglycan, and non-collagenous around 5%, which includes the osteocalcin, osteopontin, bone saloprotein, osine, which is a scleroprotein, oseomucoid, a mucoprotein, oseoalbuminoid, which is a keratin. Coming to the classification of alveolar bone. Now, the classifications mainly depend on various functions as well as the appearance. Now, based on the functional adaptation, alveolar bone can be classified into alveolar bone proper and supporting alveolar bone. According to the composition, the Kevitz classification like hypocalcemic, normal, and hypercalcemic. Whereas radiographic appearance, it can be divided into type 1 and type 2. Now, type 1 is mainly found as horizontally in a ladder-like arrangement, and it is regular, interradicular, or interdental trabeculae, and it is mainly seen in mandible. Whereas type 2 is irregularly arranged in numerous delicate interdental and interradicular trabeculae, and it is commonly seen in maximum. Another classification is based on histology. That is, you might be knowing what is an immature bone and as well as a mature bone. And here also, like any other bone in our body, alveolar bone also has a mature and immature kind of composition. And gross morphology, based on gross morphology, it is alveolar process and basal bone. Alveolar process can be further divided into alveolar bone, bundle, and lamellar, inner and outer cortical plate, trabecular bone, interdental septa, and interradicular septa. Now, coming to the development of alveolar bone. You should know that the development of alveolar bone plays a very important role, especially it happens only if there is the presence of tooth. Tooth is actually a very important factor for the development of alveolar bone. Now, it starts at the end of second month of intrauterine life. So that means tooth germs or the tooth follicle is essential for the development of alveolar bone. The outer and inner plates of the body of the mandible and maxilla will grow in a vertical direction, forming a groove that is open towards the oral cavity. Now, the tooth germ and the alveolar nerve as well as the vessels lie in this groove. Now, developing tooth germs, as I told you, they actually guide the formation of the alveolar bone. Major portion of this alveolar process begins with root formation and eruption of the teeth. During rapid growth, alveolar crest shows characteristic of cartilage and bone, and hence it can also be termed as chondroid bone. So this can be asked as a viva point of view. At what time it is called as a chondroid bone? Gradually, bony septa will develop between the adjacent tooth germs. And it mainly, what is the ossification which is happening in alveolar bone? It is nothing but the intramembranous ossification. Once developing tooth germ reach bell stage, we know there are different stages in tooth development, coming from the cap stage to bell stage to advanced bell stage. In alveolar bone, once the tooth reaches the developing bell stage, the developing bone forming cells, which is closely related to tooth germ, that will proliferate and result in formation of the alveolus. Resorption mainly occur on the inner wall, whereas deposition occur in the outer wall. The morphology of the alveolar bone depends mainly on the size, shape, function, and location of the teeth, and it depends on the tooth germ. Okay, so in case of anterior tooth, it is just in a single socket, whereas in case of a multi-radicular tooth or molars, you find that the socket is developed according to the morphology of and size of that tooth. All these teeth are separated by interdental septa. The onset of root formation mainly results in interradicular bone development. Only if there is multiple root formation, that will result in interradicular bone. That is a bone formed between the roots of the teeth. Once the alveolar socket is formed, the mandibular canal, which is located towards the base bone, that is separated from the dental crypt by a horizontal plate of bone. Hence, tooth germ plays a very important role, and hence the alveolar bone is also termed as a tooth-dependent bony structure according to Schroeder et al. Now, in this picture, you can appreciate that once the inner enamel epithelium, that is the bell stage, is formed, you can appreciate that the dental follicle has formed. Dental follicle, which is surrounding that, will stimulate the osteoblast, and that will result in the development of alveolar bone. And as I told you, it is nothing but intramembranous ossification taking place. So as a result, an ossification center will appear in the fibrous connective tissue. The selected centrally located mesenchymal cells will cluster, and that will differentiate into osteoblast, forming an ossification center. Now, the bone matrix or the osteoid is secreted within this fibrous membrane. The osteoblast will begin to secrete the osteoid, which is mineralized within a few days. The trapped osteoblast will finally become the osteocyte. Coming to the structure. So now we understood how is the development of alveolar bone. Now we'll come into the structure. Now basically, our jawbone can be divided into alveolar bone and basal bone. And there is a very arbitrary line dividing the alveolar bone from the basal bone. So that can be actually identified as the end of the roots, or the tip of the roots can be that arbitrary line. Now we'll go into detail of the structure. Now, as we learned, according to the function, the alveolar bone can be divided into alveolar bone proper and supporting alveolar bone. Alveolar bone proper can be further divided into lamellated bone and bundle bone, and supporting alveolar bone further divided into cortical plate and spongy bone. Now, coming into the parts of the alveolar bone proper in detail, that is, here we have can appreciate that the alveolar bone proper is the pink line, which is very adjacent to the root, and it is inserted by the periodontal ligament fibers. And the brown color here, this is the spongy bone or the supporting bone, and the red marked is the outer cortical plate, and the blue, which is marked here, is the inner cortical plate. So the supporting bone is located or found between the alveolar bone proper as well as the cortical plates. Supporting alveolar bone is further can be divided. First, we'll go into the alveolar bone proper. Alveolar bone proper, as I said, it surrounds the root of the teeth and gives attachment to the periodontal ligament fibers. Numerous periodontal ligament comes and attaches, and that will help in the anchorage. Around 0.1 to 0.4 millimeter thickness is found around the tooth. Alveolar bone proper has around 0.1 to 0.4 millimeter thickness, and it is characterized of a fine hole sieve. And you find that there is numerous sieve-like canals found in this alveolar bone, which is found more in coronal and the apical region of the alveoli, and the openings are corresponding to the Volkmann's canal. And hence it is called as a cribriform plate. Anatomically, alveolar bone can also be termed as cribriform plate or lamina cribriformis. Why is this? Because due to the appearance produced by numerous vascular channels. So here you can appreciate that this is the cribriform plate. You can find that there are numerous sieve-like vascular channels or openings, and these openings are actually help in the blood vessels, help in the transportation of blood into the periodontal ligament fibers. The next is radiographically, alveolar bone proper is termed as lamina dura. So this is another favorite viva question, and it is a radio-dense structure, which is due to the presence of thick lamellated bony trabeculation. And you find that now you'll get confused whether there is any change in composition. The composition is similar compared to the spongy bone as well as the lamellated bone. Only thing that spongy bone has numerous air spaces, whereas in lamina dura it is more dense. Now you might be wondering why it is more radio dense. It is radio dense because the X-ray beam is parallel to the line, and as a result, due to the overlapping effect, it appears more radio dense. That is interdental and interradicular septum, as seen in the previous picture. They have multiple canals, and these canals are called as Sucker-Cantle and Hirschfeld. So this is the lamina dura. Here you can identify the black arrow adjacent to the root. Now, what is the significance of this lamina dura? Lamina dura, it actually, when there is decrease in density, it indicates that there might be either infection, or it may be inflamed, or there may be resorption of the bony cavity. So that is why lamina dura is important in clinical aspects. Now, another is, we found that the alveolar bone can be further divided into bundle bone and lamellated bone. Lamellated bone is arranged parallel to the surface of the adjacent marrow spaces, and it consists of osteon and concentric lamellae, which is along with central blood vessels form an osteon. Similar to any other bone, the compact bone, and as well as it is having a osteon with a Harvesian canal in the center. Coming to the histology of alveolar bone proper, alveolar bone is made of bundle bone and compact bone. Bundle bone, the term was coined by Steen and Wien in 1925. The part of alveolar bone where periodontal ligament fibers are inserted is nothing but the bundle bone, except the transseptal fibers. All other periodontal ligament fibers are getting attached to the bundle bone, especially the Sharpie's fibers where it is embedded perpendicular to the surface. It is more abundantly found in the distal alveolar area of the premolar and molars. Compared to lamellated bone, bundle bone contains fewer fibers, and it appears dark in H&E stain and much lighter in silver staining. And bone formed in recent bone apposition area contains mainly the bundle bone. It forms mainly the bundle bone. Compact bone consists of superficial parallel lamellae and the deeper portions of Harvesian system. Now, if you look into the histology of alveolar bone proper, here you can appreciate it is the bundle bone where the adjacent to the periodontal ligament where the principal fibers are attached, and this is the compact bone which consists of the superficial lamellae, parallel lamellae, and these are the deeper Harvesian system. Here, the bundles of principal fibers are inserted into the bone as Sharpie's fibers. So here you can find the bundle bone, and these are the Sharpie's fibers, which you can see, which you can appreciate that it is arranged perpendicular to the bundle bone. These are the periodontal ligament fibers, and these are the this is the compact bone. So here you can appreciate the osteocyte, and here forms the osteome. So this is a typical alveolar bone. This is periodontal ligament with blood vessels. This is cementum and dentin. Now coming to the histology of alveolar bone, as any other bone, alveolar bone also has cells and matrix component. The cells are mainly the osteogenetic cells, that is the osteoblast, osteocyte, and the bone lining cells and the bone progenitor cells and the osteoclastic cells. Whereas the matrix component consists of organic and inorganic. Inorganic forms the calcium hydroxyapatite, and the organic forms the collagen, non-collagen, osteocalcin, osteopontin, osteonectin, bone styloprotein, etc. So these osteogenetic cells and osteoclastic cells plays a major role in alveolar bone remodeling. So in various physiological condition as well as pathological condition, there is a major role played by the osteogenetic cells as well as the osteoclastic cells. So I will come into that in detail. So here in histological section, you can find that this is the cortical plate with osteons having centrally located Haversian canal, and this B is the periodontal ligament, C is the cellular cementum, and D is the dentin. Now here also you can find that this is the osteoclast, which is located in the Hauschip's lacunae, and B is the old bone. This is the periodontal ligament, D is the cementum. Here, E you can identify it as the dentin. Coming to the supporting alveolar bone, the supporting bone consists of two parts: the cortical plate, which are made up of compact bone, and the circumferential lamellae, so concentric lamellae, interstitial lamellae, all which forms the compact bone. Spongy bone found between the cortical plate and the alveolar bone proper, as you've seen in the picture, and it is also found between the alveolar bone proper of the adjacent teeth of the multi-rooted teeth. So this is the alveolar bone proper, and here you can find the supporting bone. This is the inner cortical and outer cortical plate, and this is the supporting spongiosum. Now coming to alveolar crest. Now we learned what are the cortical plates. In spongy bone, we learned that there are cortical plates. Now this inner and outer cortical plate, they will come and meet. And this architecture depends on the position. Either it is in the anterior or posterior. Margin is thin and knife-edged in the vestibular surface of the anterior teeth, whereas it is rounded towards the posterior teeth, and it consists of longitudinal lamellae and Haversian system. In healthy mouth, the alveolar crest is around 1.5 to 2 millimeter below the cemento-enamel junction. So here you can identify this is the lamina dura. This is a radiographic appearance. So here you can clearly identify this is the lamina dura, and in between the root and this there will be periodontal ligament. This is a spongy bone, and these are the alveolar crest. So this is another picture which identifies the cortical plate, spongiosa, and the tooth supporting alveolar bone area, alveolar bone proper. Now another important vital question will be, what is the difference between this cortical bone and spongy bone? So cortical bone is around 85% of bone, whereas spongy bone is 15% of bone. So what is the other thing? First, it is air spaces. The bone composition is same, but there will be more of bone in the cortical area compared to spongy. Less turnover than spongy bone compared to for cortical bone compared to spongy bone, whereas spongy bone is having a higher turnover. Remodel about 3% of its mass each year, whereas spongy bone remodel about 25%. Cortical bone has a mechanical and protective role, whereas spongy bone has more metabolic function. So that helps in distributing the occlusal forces, and it has more of metabolic function. Another classification which we give is based on radiography. Spongiosity can be further divided into type 1 and type 2. Type 1, the trabeculae are arranged regularly and horizontally in a ladder-like fashion. It is more common in the mandible. So here you can find this the type 1. It is more commonly seen in the mandible, where you can find the step-like or the ladder-like pattern. Whereas type 2 shows an irregular arrangement of the numerous delicate trabeculae, and it is more common in the maxilla. Now, once we have finished that, what is the detail? We went into the detail of the alveolar bone proper, the structure of this bone, the supporting bone. Now, we should know that as similar to all other bones in our body, alveolar bone also has a remodeling phase. Now, what is the phases of remodeling? There is activation of osteoclast, resorption of bone, a reversal phase, formation of bone, and resting. So that it can be a physiological way of change, or it can be a pathological action. But these are the osteoclast and osteoblasts play a very important role in the bone remodeling. So here you can identify these are the Hausch's lacunae or the resorption way, and this is the bone, and osteoclast plays a very important role in bone remodeling. So this is what happens in case of the alveolar bone remodeling. So here you can find that the process occurs through a cooperative action or cooperation of different cells, that is either the osteoblast, the osteoclast, the bone progenitor cells, the bone lining cells, all of them play a very important role. So here you can find that this is a resorption phase during which the osteoclast will remove the old bone and it will create the resorption lacunae. So here you find once this is known, a reversal line is formed. Okay, a reversal line in which the mononuclear cells, that is a macrophage-like, the macrophage-like or the osteoblast precursors, will deposit a cemental line. So here you can appreciate this is the cemental line. And third is a formation phase where new bone is getting deposited. So the mesenchymal cells will convert to osteoblast, and that will get converted to the osteoblast is getting deposited, and as a result, new bone is forming here. And finally, it is the resting phase during which the osteoblast will become silent or present, and they become the flattened bone lining cells. So these bone lining cells are believed to persist as a canopy or a protection over the resorption lacunae during the bone remodeling cycle. So this is a very nice representation of the bone remodeling, where the old bone is replaced by the action of the osteocytes, osteoclast and formation of new bone. Coming to the nerve supply of alveolar bone. So now we have dealt with the definition of alveolar bone, what is the classification, the composition of the alveolar bone, the structure of the alveolar bone, what is the histology of alveolar bone, what you should identify when you get a histological section of an alveolar bone, what are the important cells which play a role in the bone remodeling of alveolar bone. Now we'll come to the nerve supply, the lymphatic and blood supply of alveolar bone. Nerve supply of alveolar bone is provided by the trigeminal nerve as well as in the mandible, and you find that the infraorbital nerve, the maxillary nerve plays a very important role, and the buccal nerve, lingual nerve, and inferior alveolar nerve and the mental nerve supplies the mandible. And the maxillary nerve also plays an important role in supplying the maxillary portion. Coming to the blood supply of alveolar bone, the blood supply is mainly the alveolar artery, and the alveolar artery will supply a very important blood supply to the periodontal ligament, as well as here it will actually make sure that the blood supplies to all the minute vessels. Minute vessels are so numerous vascular channels are there which provides blood supply to the alveolar bone. Here you can identify in the picture that a complex network of blood supplies blood to the periodontium. Coming to the lymphatic drainage is mainly to the submandibular lymph nodes. Now, what are the age changes of alveolar bone. So when you go into the clinical aspects or when we do a clinical practice, we find that there are both age changes as well as pathological changes, and we should have a good idea that whether that particular disease, that particular change is related to the age change or a pathological change. Normally, it is decreased vascularity, more irregular periodontal surface of bone, less irregular insertion of collagen fibers in osteoporosis, which is happening, and when an individual transforms from younger to an older age. But what are the other pathological changes? That is alveolar bone disease. We find that the conditions involving the loss of alveolar bone is mainly the extension of gingival inflammation, trauma from occlusion, systemic factors, periodontitis, periodontal abscess, food impaction, overhanging restoration, adjacent tooth extraction, ill-fitting processes. So all these play a major role in the formation, or it will result in infectious kind of environment. Overhanging restoration will result in gingival inflammation, and that will lead to bone loss. As well as adjacent tooth extraction will result in a remodeling of the alveolar bone. If it is an ill-fitting process, again, that will result in the bone loss. More of the occlusal force distribution itself is hampered, and that will result in bone loss. We'll go into detail with the trauma from occlusion. Now, bone destruction caused by extension of gingival inflammation. Most common cause of bone loss is extension of inflammation from gingiva into the supporting periodontal tissues. As a result, there will be mainly horizontal bone loss rather than vertical bone loss. You find that the height of the bone is reduced, and it is the most common pattern of bone loss in the periodontal disease. Bone is reduced in height, but the margins remain almost perpendicular to the tooth surface, not necessarily equal degree around the same tooth. So it may not be the same height, but there will be a reduction in height of the bone. Coming to the bony defects, then if you do a careful probing and surgical exposure required, if you do that, you can determine what type of bony defect is there. There are two types of bony defect, fenestration and dehiscence. Fenestration, it's a larger defect exposing the root portion, and dehiscence, if the defect includes the coronal alveolar crest, it is called as a dehiscence. So here you can identify fenestration means it is a larger defect where the root is completely exposed. So it is covered by only the gingiva. Whereas in case of dehiscence, this is mainly the alveolar, that is reduction in the alveolar crest. Another is the angular bone defect, where you find there is 1 wall, 2 wall, and 3 wall defect. 1 wall defect will be where the adjacent, the bone in between the adjacent tooth is getting defected. Whereas 2 wall, it affects 2 walls, that is either the mesial and the labial part, or it will include the distal and the lingual part. 3 wall includes either mesial, lingual, and distal. So 3 walls. So these are the combined defects. Normally, the bony defects are treated by using bone graft. There are different types of bone graft: autograft, allograft, and xenograft. Autograft, where the patient's own bone is taken from another area and it is replaced. Allograft, it is actually commercially available. Xenograft, we actually take from another species, so which is more biocompatible with humans. Coming to crate is another most common osseous defect, where the concavities in the crest of interdental bone is there and is most commonly seen in mandible, around 62% in mandible. This is a bulbous bony contour, it's known as exostosis, where the bony enlargements caused by adaptation to function or buttressing bone formation, and is more commonly seen in maxilla. Ledges, it is a plateau-like bone margin caused by resorption of thickened bony plate. Ledges are caused by bony resorption mainly. Coming to bone destruction caused by trauma from occlusion, where the occlusal forces exceed the adaptive capacity of the tooth. As a result, there will be injury to the tissue. So there is primary trauma from occlusion, where the alteration in the occlusal force in normal periodontium with normal height of the bone. Whereas secondary trauma from occlusion is due to reduced ability of the tissues to resist the forces in case of normal periodontium with reduced height of bone. Another is the bone destruction by systemic disease. Until now, we learned the other factors. Here we are going to deal with the systemic factors which will result in bone disease. So vitamin D deficiency, as we know that vitamin D plays a very important role in calcium regulation. Calcium is one of the major composition of bone. So again, vitamin D deficiency can result in rickets, and it also result in so the osteoclastic activity will be more, and as a result, vitamin D deficiency will result in bone loss also. Diabetes, it is a very important factor. Diabetes means there will be increased inflammation in and around the bony area, as a result, bone loss. So most of the elderly patients have diabetes, and they come with periodontitis or as well as bone infection and inflammation. Hyperparathyroidism, leukemia, Paget's disease, fibrous dysplasia, histiocytosis, osteomyelitis, central giant cell granuloma, and aneurysmal bone cyst and other systemic diseases which result in bone destruction. Coming to hyperparathyroidism, we can find that the oral changes include the malocclusion or tooth mobility. There will be alveolar osteoporosis with closely meshed trabeculae. There will be widening of the lamina dura. There will be radiolucent cyst-like spaces where the bone cyst is made of hemosidrin-laden macrophages or giant cells, and that is nothing but it is called as a brown tumor. And another condition, the condition of this is called as von Reckling-Hausen's disease or osteotis fibrosa cystica. So there are other conditions where the similar disease is found. That is nothing but Paget's disease, fibrous dysplasia, and osteomalacia. These are one of the favorite viva question of the examiners. Coming to Paget's disease where the osteoclast and the osteoclast precursors contain the paramyxoviral transcripts and appear hyperresponsive. As a result, there will be more, osteoclastic activity. There are regulators and inhibitors of bone formation, and as a result, the osteoclasts are more in Paget's disease, and there is increase in number and size. Here you can see this is a histological picture where you find there are numerous osteoclasts, and they are coming and resolving. They are taking in the bone. This is the hematological disease disorder where you find that the infiltrate will present in leukemia, especially the infiltrate is present in the marrow spaces and the periodontal ligament, resulting in osteoporosis of the alveolar bone with the destruction of the supporting bone and disappearance of the periodontal fibers. Sickle cell anemia, where you find the generalized osteoporosis of the jaws. Stepladder alignment of the trabeculae and of the interdental septa, and pallor and yellowish discoloration of oral mucosa are other oral manifestations of sickle cell anemia. So these are some of the or few of the systemic diseases which result in bone destruction. So these are my reference. So now we have dealt with the alveolar bone, the composition, as well as the entire structure, the classification, and the vessels and nerves that supply the alveolar bone, and the changes, clinical consideration of alveolar bone. So let's have a small recap. The development of supporting tissues of tooth is initiated by cells of dental follicle. Attached apparatus of tooth is composed of periodontal ligament, cementum, alveolar bone. Bone adjacent to periodontal ligament that contains numerous Sharpie's fibers, or the principal fibers of periodontal ligament are attached to bundle bone. Alveolar bone is also known as lamina dura. Type of bone present in labial area of anterior teeth, cortical bone. Which group of fibers are not attached to the alveolar bone? So it is nothing but transeptal fibers. So numerous questions will be asked related to alveolar bone. What is alveolar bone? What are the structure, alveolar bone and structure? Give a description about the histology of alveolar bone. What is the importance of alveolar bone as a supporting structure of the tooth? These are and few of the clinical considerations of alveolar bone. If a short essay is asked, you have to write the definition, the function, development, composition, classification, histology, and age changes and diseases. If it is long essay, you have to add a small introduction about the bone, the classification of bone, the definition, and the bone remodeling and bone formation can also be added. Hope you all understood the alveolar bone, which is a basic chapter. Thank you.